Good morning, everybody. Today we have an important lecture. It's about the tibial plateau fracture. First of all, our objective will be how to classify the fractures with the newer concepts, what are the factors leading to instability, and whether one surgery or two surgery, whether to put a single plate or two plates, when to use arthroscopy and if there is any role for the arthroplasty, and finally how to avoid the complications. Although it's called a bumper fracture, but studies have shown that most of the fractures happen with the fall from height, followed by motor vehicle accidents, and then the run over injuries, then motor vehicle accident, and lastly, sport injuries. And despite it's a high energy injury, we have to suspect it with a trivial trauma in elderly cases, as studies have shown that there is an increased incidence of the tibial plateau fracture in the osteoporosis, with osteoporosis either postmenopausal or even in the senile, especially with the female one. And even in the last decade, the rate is increasing much more. Regarding the proper anatomy, we have a lot of intra-articular structures we need to be careful about. The menisci, articular cartilage, cruciates, and collateral ligaments. With the compression force, mainly the meniscus and the articular cartilage are at greater risk, while cruciates and collaterals are at greater risk with the tension force. So if we have a valgus stress, there will be a compression over the lateral plateau and the MCL will be at risk for rupture or strain. While with the varus, there will be more compression force over the medial one and the strain will be happen on the LCL. With more axial load, there will be much more higher risk of injury for the both plateau fractures. The presentation cases with a tibial plateau fracture may present with a painful, swollen, or bruises around the knee, and they may present with a wound or deformities. Before taking the X-ray, we need to check the followings. First of all, check the distal pulse because there is a high incidence for vascular injury with these high energy fractures. Second is the compartment syndrome, and the most important sign clinically is the pain out of proportion, especially with the passive stretch. And whether there is a foot drop or not, because common peroneal injury is common feature with the high energy fractures. Instability tests are somehow painful and they are not conclusive. That's why it's not recommended. In the X-ray, we have the AP view to show the fracture pattern. We have the lateral view, which may show the posterior involvement. We have the oblique view to show the size and the location of the fragments. We have citrus view to give us some clue about the instability and the suspicion of the ligament injuries. We have Rosenberg intercondylar view or the plateau view. These views are more important for the articular involvement, whether there is a depression or not. But still, CT scan is the gold standard. Whenever we have a case with an intra-articular fracture, send for the CT to show the coronal plane, sagittal plane, and the axial plane. And simply, this is because that we can show the fracture very well with the CT scan. So if we have a fracture in the both condyles, and with this 3D, we can see that this posterior fragment that needs to be fixed by a buttress plate, which cannot be seen by the simple X-ray. That's why the newer classifications nowadays depend on the CT. The most popular classification is the Schatzger classification, and then the AO, and then Schatzger have been modified, the newer columns, and the segment concepts. The first two, Schatzger and AO, they depend on the radiograph, while the last three classifications they depend on the CT. These are the newer ones. So starting by Schatzger type 1, when we have a valgus injury, then there will be a split on the lateral plateau, and we will have a split fracture of the lateral plateau, and there is an injury for the MCL. There is a risk for the MCL injury. In Schatzger type 2, we have valgus with an axial load. That's why we may see split and the depression fracture there. In Schatzger type 3, we have more axial load than the valgus, so there will be impaction over the lateral side without split. In Schatzger type 4, we have two mechanisms. either by severe valgus causing an avulsion of the MCL and lateral impaction, or we have a severe varus making the impaction over the medial one. It is very high energy trauma and may cause an LCL disruption and common peroneal nerve injury. In Shasgar type 5, we have axial load that causing both condyle fractures. And Shasgar type 6, which is the most nasty one, it may occur with the more axial and severe valgus one, causing both condyle fracture and dissociation between the metaphysis and the diaphysis. AO have classified the proximal tibia to 4-1, 4 for tibia, 1 for the proximal. Type A is an extra-articular, which is not our subject. Type B is a partial intra-articular, so it is one condyle fracture, either split or depressed or split and depressed. Type C, which is a complete articular, which is a both condyle fracture, and C1 is without comminution, while C2 there is a metaphyseal comminution, and C3 we have articular comminution. Shasgar classification have been revisited later on because the studies have shown that the posterior fragment should be reduced and fixed with a buttress. And Shasgar, the original one, it depends on the 2D. That's why the newer Shasgar nowadays, it depends whether the fragment is anterior or posterior. So if it is anterior with the lateral, we call it 1A. If it is posterior with the medial, we call it 4P. If both anterior and posterior on the lateral, we call it 1AP, and so on. People, day by day, they are creating more specific classifications. One of them is the column principle. They classify to it as a lateral column, medial column, and posterior column. And some of them, they go even further for 4 quadrants classification. And surgeons are starting to make a very specific clarification, where is the fracture? And most of them nowadays, they are segmenting the fracture either 10 segments or 9 segments or even 7 segments. So there are a lot of classifications we cannot go through, we cannot cover all of them. We have some principles that we can depend over it in a practical point of view. So we have some features that will go with the temporary stabilization is the most preferable option. First of one is a polytrauma. When we decide to do a damage control surgery, so we go for the X-fix. If we have a soft tissue compromise, either with an open fracture or compartment syndrome or severe edema that we cannot implant any plate at the current state, so we go for the external fixation. In the open fractures, we follow the same rule for other fractures. One exception is that it's intra-articular fracture. So we need to take care about the joint. We either cover it, or if it is not coverable, we keep it moist. In the compartment syndrome, we follow the same rules of other fractures. First of all, by clinical examination. Second is by measuring the intracompartment pressure and doing fasciotomy if it is more than 30, especially if the delta pressure is less than 30. Timing is quite important, as if we pass the 8 hours, so necrosis have started, and most of the articles nowadays, they show that the doing fasciotomy with the necrosis have a higher risk for amputation later on. Bone should be stabilized with an X-fix, and keep in mind to keep these loops over the fasciotomy wounds because to keep the edge approximate. Whether to do the surgery with 1 stage or 2 stage, there's a controversy. First of all of the surgeons previously they were doing ORIF for all high tibial plateau fractures in 1 stage. But later on, they have found there is a wound problems with high energy fractures. So the principle of stage surgery have come through with an indication for stage surgery in a 2 condyle fracture. Articles later on showed that cost is very high and the reduction is very difficult in the definitive surgery. That's why people are starting again to do it with 1 stage surgery. Uno in 2017, he defined a criteria for his 1 stage surgery that if timing of the surgery is not passing 72 hours and if there is no circumferential blister, he will go for the 1 stage surgery. And his studies showed that 16% of reoperation and 9% of deep infection. Another one, which is considered as a more safer one by Virkos in around 2 years ago. He defined the indication for two-stage surgery if the time more than 24 hours or any blister, he considered it as a contraindication for one-stage surgery. And his results was much better than the previous one with 7% of reoperation and 7% of deep infection in comparison with a higher percentage of reoperation and deep infection with the two states. Now, these are the factors for the temporary stabilization. We have good signs that represent that the fracture is a little bit benign and we can manipulate with it with either conservative or doing percutaneous fixation. And there are signs for instability and signs for bad situation. Let us take the signs of instability. They are bad. Remember it as BAD. B for buttress is mandatory. A for articular comminution. D is for a depression fracture. What do you mean by buttress is mandatory? If we have a medial column fracture, so with the axial load, this fragment will displace. So we need something to buttress it here. If we have a lateral column fracture, it's considered stable as far as the fibula is intact. But if we have a fractured fibula with this axial load, we will have an unstable fracture and we need a buttress plate. If you have a posterior column fracture, so there is nothing to support it, so at the end we need to buttress this fragment. And one important point that the buttress plate should be positioned over the fracture apex. So these are the places where the plate should be. And remember that a medial plate is not a buttress plate for a posterior fragment because it's not just capturing the fragment by a screw. The buttress plate has its principle. What about the articular comminution? If we have an anterior fragment, we can reduce it and then we can make a lag screw for it. It's quite good. If we have a posterior, so we need to make the lag screw over the posterior, and again, it's a good. If we have both anterior and posterior, but it is less comminuted, so we can reduce them and make the lag screw to compress them together, which is good. But lag screw is very bad idea when we have a severe comminution. Instead, alternatively, we can do it in a better way. We restore these fragments and then we put positional screws. And this technique is called a rafting technique because more lagging screw over a comminution side will make an over tightening. This is one of the ABCs in orthopedic. What about the depression fracture, which is considered as unstable fracture? If we have an rim impaction, whether it's a lateral or medial, it's considered as unstable because it will lead to joint instability. If we have a medial impaction, regardless the depth, it's considered unstable because it will lead to collapse. But if we have a lateral impaction, if it is more than 5, so it is unstable, while less than 5, let us say it's relatively forgivable. So how to restore these? It's restoring by a bone impactor, creating a window through the bone, and then to put some structural graft to support it, and then to support it by screws. If I have posterior fragment, so studies nowadays, they are showing that we are not going through the anterior to the posterior to replace it, so that we jeopardize the anterior column and the posterior column is already compromised. So we go from the posterior and replace it with the same mechanism. AO is recommending a plate for every depression fracture because they think that the window that created with the cortex, they are making the bone or column weaker, so we need to buttress that column. But there are studies about the balloon tibioplasty. It's the same device that using in kyphoplasty. So one of the studies is by Grimmel in the last year. He was marking the fragments by the arthroscope and then with checking with the fluoroscope where is the fragment, and then inflating the balloon, and then filling this balloon with the calcium phosphate, and then retracting them and supported by screws. And at the end of the result, his results was showing that 20 to 25% of the cement was absorbed and replaced by a cancellous bone, which he considered as successful. These are the signs for the instability. Before going to the good signs or bad situation, let us have a look about the approach. In the approach, we have the anteromedial approach, anterolateral approach. It's the by arthrotomy in the anterolateral, which is the most common approach used. And we have the minimal invasive approach, the Myo approach. We are going posterior to the Gerdy tubercle so that we are not going to do arthrotomy. That's why arthroscope it will be helpful in this approach. We have anteromedial approach for any medial fragment. We have posterior or posterior medial approach by reflecting the medial head of the gastrocnemius. In the posterolateral approach, we have different approaches. One of them is by fibular osteotomy, and later on, the LCL will be repaired by putting the bone back in place. And we have what's U approach have mentioned by fibular osteotomy without sacrificing the LCL is intact. And the last one is the Leo in 2016 approach is without fibular osteotomy and without exploration of the common peroneal nerve. He is going 1.5 centimeter medial to the fibular head, so he's very away from the common peroneal nerve. These are the approaches. Now we are going to talk about the management. First of all, the good signs of a fracture is good bone quality, one condyle fracture. Open reduction is not necessary, like if it is non-displaced, or we can reduce it by close method, or demand of the patient is very low. So starting with the most benign one, which is the minimal displaced or close reduction can be done for it. In a close reduction, we are using clamps by creating two stab wounds there. The lag screw should be perpendicular to the end to the fracture line, so that's why this will determine your entry. Determine your entry. And if your entry is very close to a nerve, so you need to make an incision rather than just a stab wound. And if you are struggling with the reduction, so maybe the lateral meniscus is interposition between the fragments, so it's better to do arthrotomy in that case. When we check the fluoroscope, if it is good, so we stabilize it by a provisional K-wires, and then we put two cannulated partial threaded screws like in this one. Arthroscopy has very important role in fractures, type 2 or 3 or 4, because we can see concomitant articular injury and address them. We can see the reduction very well, and especially the medial port is quite better than the lateral port because we can see the lateral plateau very well. But be careful about the extravasation from arthroscope. That's why some of the surgeons, they are recommending to do the arthroscope over a period of time, not in acute phase. Now we come across for the one condyle fracture. These fractures considered more stable than the both condyle fractures. The principles are the articular reduction should be anatomic. If we have a split fracture, if we have depression, we need to elevate and support with a graft. Then the lag screw should be perpendicular to the fracture line here, even with the medial one. And if we have severe osteoporosis or severe comminution, so we go for the Raftek technique, which is the positional screws rather than the lag screws. Position of the plate is very important because in the lateral plateau fractures, if we have a posterior one, we cannot address it from the anterolateral approach. So from the beginning, we have to choose either posterior or posterolateral approach to go for them. So if we have a fracture in the anterolateral quadrant, we can do with the anterolateral approach. If we have posterolateral plate, posterolateral fracture, so we can do it with the posterolateral plate by posterior or posterolateral approach. Anterior medial fracture and posterior medial fracture can be addressed by the medial approach or posterior medial approach. Regarding the both condyle fracture, here we will have some extra things to be careful about. First of all, if we have comminution, please use distractor because it will make it very simple for you to make the ligament ataxis by the distractors. In the articular surface for the C1 and C2, when there is no comminution, so lag screw is important. But if you are using the less invasive stabilization system, I mean the locking minimal invasive plate, so put the lax screw out of the plate because the plate has a place for the locking screws rather than lagging screws. In C3, when we have comminution in the intra-articular, so we need to elevate and support plus minus lax screws if it is less comminuted, as we mentioned before. For the medial plate, the only indication nowadays when we have a posterior medial fragment that cannot be stabilized by Lisp plates. Lisp plate is the standard nowadays because it can be used with a soft tissue compromise because it is less invasive. It can be used as a bridging plate with the metaphyseal comminution. It has a looking screws, so it's very good with the osteoporosis. And even for both condyle fractures, we can use LIS alone for the medial fragment, not for the posterior medial fragments. Some tricks in the technique, we can use them with the Mio approach, and we should keep some interval between screws. This will decrease the stress over the plate. And the distal window is very, very important for two things. First of all, we are going minimal invasive, and there is a risk for the superficial peroneal injury. So that's why we need to visualize the distal pole of the plate, whether the nerve is trapped between the plate and the bone. And second, for centralization of the plate to avoid this phenomenon. So that in this phenomenon, we will have an eccentric purchase, so the working length of the screw will become less. Whether to use a one plate or not, people are still in controversy about it, because people who care about the wound, they are still with the single plate, and people who cares about stability, they are with the dual plates. So first of all, they were started by a single incision, and it was very difficult to do two plates with a single incision. That's why most of the surgeons at that time, they were using a single plate. Later on, surgeons are started to do dual incisions that so they can put two plates. Later on, with the development of the locking plates, studies have shown that a single locking plate is similar or even more stable than two conventional plates. And the idea behind that the conventional plate, the screws are not angularly stable. That's why the medial fragment, it keep moving, while with the angular stable system, so this medial fragment will not move with using the locking plates. Later on, with the MIPO technique, with the LIS technique, this nowadays is the standard for all both condyle fractures, unless we have a posterior medial fragment that need to be buttressed by a posterior plate. This is the only indication for the dual plates nowadays. Lastly, we go for whether there is any role of the arthroplasty or not. One of the studies done last year was by Abdul Badi. He was comparing between doing ORIF or STEM, total knee arthroplasty, directly for people who are older than 60 years and Shasgar type 2, 3, or 4. He was using less damicide as a reference, and he was doing structural bone grafts and metal blocks augmentation with the tibial component with a stem. And the pre-op parameters was quite comparable between both, while the post-operative, they were much favoring for the total knee replacement because higher flexion range and higher knee score with less infection and less varus. What are the possible associated injuries, intra-articular pathologies? Lateral meniscus has a risk with the type 2 and type 5 Shasgar, and it's more risk with the depression exceeding 6 millimeter, and widening of more than 5 millimeter is a risk factor for lateral meniscus injury. And even Kolb, he stated that 1 millimeter of widening is representing a higher risk for lateral meniscus by 40%. ACL risk factors are Shasgar type 2 or 3, and with the type 4, 5, 6, they may get avulsed more than gate torn, and the medial displacement more than 3 millimeter, ACL has a risk, and it has much more risk with the anterior medial and posterior lateral quadrants. Medial meniscus with the Shasgar 5, and MCL with the Shasgar 2 and 3, and the PCL, PLC, both with the Shasgar type 4. Sabisan have put some protocol for the collaterals or cruciates concomitant with the tibial plateau fractures. We can cast any partial collateral. We can repair if there is a complete collateral injury. Cruciates, if there are avulsion, we can fix them. If they are mid-substance, we can put them for the later constructions. What are the complications with the tibial plateau fracture? The first one is the compartment syndrome. Early recognition is the best solution for the compartment, especially with the high Shasgar grades and dislocations. Infection, we can avoid it by being very gentle with the tissue, using minimal invasive technique and going directly to the segment that need to be fixed. And if we have blisters, if the time is more than 24 hours, so we go for the state surgery is safer. Stiffness, and the solution is a stable fixation to do early mobilization. Malunion, we can avoid it by using a better stable structural support like graft or tibioplasty. And arthritis is common with these fractures. So the good things to be remembered that anatomical reduction and meniscal preservation and the collaterals repair are quite important. Finally, as a take-home message, CT-based classification helps better in planning. Buttress plate is needed always, except when there is a lateral split fracture with intact fibula. Articular restoration is needed unless less than 5 mm in lateral depression fractures. Fracture reduction is easier if we do it with one-stage surgery. We consider two-stage surgery in severe soft tissue compromise, like in the presence of blisters. Single Lis plate is stable even in bicondylar fracture, and the only indication for medial plate is the posterior medial fragment needing buttress. Arthroscopy role in Shasgar 2, 3, 4, especially with the minimal invasive approach. Arthroplasty has better outcome in patients older than 60 years with a pre-injury arthritis. Choose the best approach to increase unnecessary dissections. So this is the final slides. We have a lot of factors. The last thing to say is every case is a special case. We cannot apply all the rules in every case. So the ideal job is to choose the best approach for and using the best implants for the suitable patients. So this is what's called a la carte module. Thank you so much.